Thank you again for joining us for LHON Awareness Day webinar as part of World Mitochondrial Disease Week. I'm Jo DeBry. I work with IMP, and we're excited to see so many of you joining us today. I would like to introduce Paula Morandi, who is the chair of IMP, to say a couple of words.
Today, on September 19th, is International LHON Awareness Day. We are honored to come together as a global community of patients, families, researchers, clinicians, and advocates. This day is more than just a mark on the calendar. It is a powerful reminder of how far we've come in understanding Leber's hereditary optic neuropathy, LHON, and other mitochondrial diseases, and how far we still have to go. At International Mito Patients, our mission is to connect, support, and empower those affected by mitochondrial diseases across the globe. Nutrition, as today's topic reminds us, is not just about food, it's about hope, function, and quality of life for all people living with mitochondrial disease. Nutrition can play a vital role in how symptoms are managed and how energy is sustained. Yet it's also a deeply personal and sometimes overlooked area of care. We are incredibly privileged to have three distinguished guest speakers with us today, each bringing a unique perspective, deep expertise, and compassionate insight to the evolving relationship between nutrition and mitochondrial function. From Melbourne, Australia, we welcome Dr. Isabel Lopez Sanchez, whose work in mitochondrial biology and disease has helped shape best practices and patients' care. Joining us from Italy, we have Dr. Marzia Camera, a clinical nutritionist and physician who has worked closely with patients to translate science into everyday dietary strategies. And from Brazil, we are honored to have Dr. Felipe Chicani, a leading researcher whose work bridges clinical research and practical recommendations for metabolic health in mitochondrial patients. Each of them brings a cultural and scientific richness that reflects the global nature of our community and the fact that mitochondrial disease knows no borders. This webinar is an opportunity to learn, to ask questions, share experiences, and build bridges between patients and professionals, between continents and disciplines. So thank you for being here. Thank you for caring. And let's dive into the science and the hope behind nutrition and mitochondria. Thank you.
Thank you, Paula. We would like to first welcome Dr. Camera up, who is going to talk about nutrition and mitochondrial diseases. Welcome, Dr. Camera. Thank you so much for joining us.
Good morning, everyone. I am Dr. Marzia Camera. I am a biologist and nutritionist, and I focus on nutrition in mitochondrial diseases. In 2012, I discovered that I had a mitochondrial disorder. At that point, I asked myself, how can I use my knowledge from my wonderful profession to help myself? So I combined my scientific background with the limited medical literature available, and with both my personal experience and experience of other mitochondrial patients. The result of this work allowed me not only to help myself, but also other people living with mitochondrial disease. Today, I'll be talking about the importance of vitamins in mitochondrial disorders, especially in relation to vision. We'll also look at how nutrigenetics can support mitochondrial patients. But first, a few key points to set the stage. Let's start with a quick review. What is a mitochondrion? It is a small organelle inside our cells. It has two membranes, inner membranes with fold called cristae, and outer membrane made of phospholipids. In the mitochondrion, we find the matrix home to enzymes, ribosomes, and mitochondrial DNA. Its main role, carrying out cellular respiration, which produces the energy our cells need for metabolism. Another quick division, Leber's hereditary optic neuropathy, LHON. It's a mitochondrial disorder that primarily affects the eyes, causing degeneration of the optic nerve and progressive vision loss.
Dr.
The result of this work allowed me not only to help myself, but also other people living with mitochondrial disease. Today, I'll be talking about the importance of vitamins in mitochondrial disorder, especially in relation to vision. We also look at how nutrigenetic can support mitochondrial patients. But first, a few key points to set the stage. Let's start with a quick review. What is a mitochondrion? It's a small organelle inside our cells. It has two membranes, an inner membrane with folds called cristae, and outer membrane made of phospholipids. In the mitochondrial, we find the matrix home to enzymes, ribosome, and mitochondrial DNA. Its main role, carrying out cellular respiration, which produce the energy our cells need for metabolism. Another quick definition, Leber's hereditary optic neuropathy, or LHON, it's a mitochondrial disorder that primarily affects the eyes, causing degeneration of the optic nerve and progressive vision loss. Sometimes LHON is also linked in other conditions, including muscle problems, dystonia, neurological issues, and cardiac complications. Now let's move on to vitamins. They are essential elements for our body. Many of them cannot be produced internally, so we must get them through food. They divide in two categories, water-soluble, mainly the vitamin B and C, and fat-soluble, A, D, K, E. Vitamins play key roles in metabolism and physiology. They can act as coenzymes, regulators, and overall supporters of our health. But today, we'll focus on how they affect eye health. The most important vitamins for the optic nerve and vision are vitamin D, C, B, E, A. And let's not forget, mitochondrial patients should always include antioxidant and anti-inflammatory food in their diet. Here's a quick overview. Vitamin A supports night vision and retinal function. Vitamin C helps prevent cataract and support the vascular system in the eyes. Vitamin E directly supports eyes function. The B vitamins each play specific roles that we look at shortly. And vitamin D, which is perhaps the most important for overall health. Let's start with it. Vitamin D comes in two main forms: D2 found in plants, D3 which we produce when our skin is exposed to sunlight, and which we can also get from animal source. It is crucial for the skeletal, immune, intestinal, and pancreatic, kidney, and glandular system, and especially for eye health. Researchers at Institute of Ophthalmology, University of London, suggest that vitamin 3 actually helps keep the retina younger. It plays a key role in the immune regulation, which in turn protect the light-sensitive nerve tissue and the eyes from aging. About 19% of vitamin D is synthesized in our skin through sunlight, but a study published in Neurobiology of Aging showed that even supplement with synthetic vitamin D3 in mice helped in slowing vision decline. Prevalence of vitamin D deficiency. Studies show that vitamin D deficiency is truly a global pandemic affecting both children and adults worldwide. This deficiency has been linked to countless acute and chronic diseases, including vision problems. That's why it's essential to test for vitamin D levels and treat deficiencies appropriately. Another study stressed the importance of supplementing vitamin D early in children and adolescents to prevent them from growing into adults with long-term deficiency and related conditions. So, why is vitamin D deficiency so common? Why are there different conditions that interfere with vitamin D metabolism? First of all, latitude. Above the 30 feet parallel, both north and south of equator, it is not possible to synthesize this vitamin from November and to Mars. For example, Turin is located at the 45th parallel north. Another interfering factor is altitude. In the mountains, more UVB rays are received compared to sea level, and the time between 10 a.m. to 2 p.m. is when the body absorbs the most UVB rays. Two more conditions are air pollution, which block UVB rays, and cloudiness. On cloudy days, UVB rays are reduced by half. Another factor interfering with vitamin D metabolism is the use of sunscreen, which is essential but unfortunately acts as a barrier to absorption of vitamin. The last interfering factor is the amount of melanin in our skin. Darker skin, which contain more melanin, produce less vitamin D when exposed to sunlight because melanin captures UVB rays and surface and prevents them from stimulating vitamin production. What should we do? Certainly, measure vitamin D levels with blood test. If the blood test reveal a deficiency or if the condition requires higher levels of vitamin D, we need to supplement it through diet. And for us, with it a mitochondrial disease, Here in the slide, I've included a brief summary of the study conducted on vitamin D related to muscle tone and trophism. It showed a clear improvement in mitochondrial function in the muscle of subjects with vitamin D deficiency and taking a fixed dose for 10 to 12 weeks. Therefore, it's evident that vitamin D is important and essential for the people with mitochondrial disease. The absorption of vitamin D is also closely linked to our microbiome. What is the microbiome? The microbiome is the collection of symbiotic microorganisms living inside and outside our body, along with all their genetic material. We are colonized by these microorganisms in the truest sense of the word. They are spread everywhere on our body and are essential for our survival. The gastrointestinal tract is the organ most directly in contact with external microenvironment, mainly due to environmental microorganisms present in food we ingest, which can also be potentially harmful. It is also the organ with the most diverse microbiome. How do we relate vitamin D to intestinal microbiome in mitochondrial patients? Vitamin D is mainly absorbed in the duodenum, in the intestine. A vitamin D deficiency is closely related to intestinal inflammation and intestinal dysbiosis, meaning an imbalance between pathogenic and beneficial bacteria that make up the intestinal microbiome. Vitamin D in the intestine modulates microbiome function, controls the expression of antimicrobial peptides, and has a protective effect on the intestinal mucosa. It is important to remember that the human body is constantly exposed to foreign antigens and pathogens. It has therefore developed protective mechanisms to keep control over opportunistic microorganisms and prevent harmful effects for parasites and that attack us from outside. One of the main protective mechanisms is having a healthy microbiome, which also allows us to absorb vitamin D. It is important to underline that the role of the microbiota is not limited only to the cells. Act as a real organ and is therefore involved in same physiological process of our body. It is an integral part of us, developing already in the womb. Alteration and imbalances in quality or in quantity can have dangerous consequences for health, quality of life, and life expectancy. Since vitamin D is fat soluble, we find it mainly in fatty food like as salmon, sardines, mackerel, and cod liver oil, eggs, and dairy. Plant sources include mushroom and fortified food like cereal, juice, and plant-based milk. But remember, the main source is still sunlight. Next up, vitamin A. This vitamin is vital for vision, especially night vision, because it's a component of rhodopsin, a protein in retinal rod cells that work in the low light. A deficiency can cause night blindness and dry eyes, or even total blindness. Food rich in vitamin A include carrots, pumpkin, milk, eggs, and liver. Let's move on to the B vitamins. They are very important for eyes health because they are prevent macular degeneration, support the eyes muscle, and reduce inflammation. The ones we are most interested in are B1, 2, 6, 12, and 9. In detail, B1 contributes to optic nerve health and prevents macular degeneration. Similarly, B6 help counteract cataract formation and macular degeneration. B12 is also important for the optic nerve and to prevent glaucoma. Finally, B9 or acid folic is essential for the entire cardiovascular system, especially for circulation in the eyes. Here are some examples of food rich in B vitamins: meat, chicken, pork, liver, egg, cereal, legumes, green vegetables, and nuts. As you may have noticed in the previous slide, there was an asterisk next to vitamin B12. This is because even if it is very important, helping the optic nerve by contributing to the formation of the myelin sheath, but sheath that covers and protects nerve fiber. Some studies have shown that cyanocobalamin, the synthetic form of B12, can be harmful for LHON patients. Even if a vitamin B12 deficiency can cause a severe vision damage or even blindness, as in nutritional optic neuropathy, B12 should not be artificially supplemented in LHON patients. In a summary, vitamin B12 supplementation, especially injectable form, may worsen condition in predisposed individuals, causing vision deterioration. Therefore, it is important that people with LHON's disease consult their doctor before taking B12 supplement. The situation is very different for food, naturally, containing vitamin B12, which can safely be consumed. Vitamin B12 is mainly found in animal-based food such as meat, fish, egg, milk, and beef liver. Beef liver very rich in vitamin B12 and a smaller amount in vegetables and algae. Now let's consider vitamin B9 or folic acid, which is very important for reducing cardiovascular risk. It is essential for women from menarche and menopause, protects against cellular damage, interacts with physiological aging, protects muscle and support vision. It is found mainly in green vegetables such as spinach, broccoli, asparagus, lettuce, in orange, legumes, and cereal, and fruit such as kiwi and strawberry, and also in liver. Unfortunately, cooking destroys much of the folic acid in food, up to 50%. It is a vitamin produced in small amount by the intestinal bacteria flora. so it is important to get it from food. Folic acid should ideally be consumed at most meals, but not with food that reduce absorption, like coffee, red meat, chocolates, nuts, or shellfish. Best to spray them apart. Here are some berries that contain folic acid. Now let's move on to vitamin C, ascorbic acid, a water-soluble vitamin with strong antioxidant properties. It provides many benefits, such as protecting against free radicals, stimulating the immune system, and participating in many metabolic reactions. Above all, it's essential for iron absorption. Even if vitamin C is important for protecting nerve cells from degeneration, current ophthalmological studies do not provide enough evidence to recommend vitamin C as a treatment for LHON. So, why should we take it? Simply because of all the benefit it provides. It helps prevent further illness, reduce free radical and inflammation that can worsen mitochondrial disease, supports good overall health, and reinforces the immune system. Vitamin C is mainly found in fresh fruit and in vegetables: peppers, kiwi fruit, strawberry, tomato, leafy greens, guava, and papaya. It is important to note that the human body cannot produce vitamin C, so must be obtained from diet. Vitamin C dosage depends on age, but it's worth remembering that excess vitamin C is eliminated directly through urine. Vitamin A is a fat-soluble vitamin with antioxidant properties. It protects cell membranes for free radicals, influences gene expression, and regulates enzyme activity. Food rich in vitamin E include seed oil, butter, soy, corn, nuts. In general, food contains oil. Other essential nutrients for vision are lutein, omega-3 fatty acid, zinc, selenium, thiamine, zeaxanthin, and beta-carotene. A key point: some vitamins, especially fat-soluble ones, are best absorbed with dietary fats. For example, a study showed that people who ate salad with olive oil had higher levels of absorbed nutrients. Extra virgin olive oil is especially effective here. Some of the best foods for vision include soy, eggs, fish, nuts, avocado, berry, broccoli, and green tea. Even dark chocolate, which contains flavonoids, is beneficial for vision, and is red one because it contains resveratrol, which protects the macula. For optic nerve health, it's crucial to avoid the toxin, especially tobacco and alcohol. And finally, always aim to get vitamins directly from food, but when there is a real deficiency, a supplement may be needed, always under medical guidance. Now, I would like to take to you about genetics applied to nutrition. First of all, let's distinguish between nutrigenomics and nutrigenetics. Nutrigenomics studies how nutrients influence the activity of our genome. while nutrigenetics studies the influence of genetics variability on nutrient metabolism. Genetics can help us improve vitamin absorption, reduce cellular inflammation, decrease free radicals, and therefore have an antioxidant effect and improve the health of our gut. Most important, it can improve the effectiveness of the medication and supplement we take. This is an example of a panel for mitochondrial patients. In this panel, specific genes are analyzed that may worsen the disease or predispose to other conditions. In this panel, which I specifically designed for mitochondrial patients, we analyze lactose intolerance, folic acid and vitamin D absorption, inflammatory status, fatigue, and acid accumulation, antioxidant activity, lipid profile, and also predisposition to celiac disease. Once it is discovered that we have mutation for polymorphism in these genes that prevent the proper functioning of enzymes they produce. Nutrition can be used to counteract their negative effect on our health. The panel also includes the screen of 5 genes whose polymorphic variants predispose to inflammatory bowel disease and also alter intestinal homeostasis and microbiota. From the test results, it will be possible to identify a target diet that counteracts the negative effect caused by this mutated gene and a specific prebiotic and probiotic supplementation to restore a state of eubiosis. This is the intestinal microbiome panel, where there's 5 genes of our nuclear DNA are analyzed. To conclude, let's summarize how a mitochondrial patient should eat. It is important to remember that every mitochondrial patient has specific nutritional needs derived from the alteration of energy metabolism typical of this disorder. Certainly, all mitochondrial patients must consume antioxidant food, reduce pro-inflammatory foods, follow a genetically based diet, as I mentioned earlier, and balance the pH of food. Therefore, since there are no official dietary guidelines for mitochondrial patients, the only certainly is that prolonged fasting both of liquids and food must absolutely be avoided. A balanced diet must be maintained, and growth and BMI must be monitored in children. What should we absolutely not to do? Consume more carbohydrates than proteins, because proteins are important for our muscle. What should we do instead? Have 4 to 6 small meals and a day, and avoid excessive calorie intake. Have a nighttime snack, not only sugar, to prevent blood sugar spikes. And for those who have the opportunity, take the DNA test. Let's now focus on what a typical day should look like for a mitochondrial patient. As you can see, every meal always includes proteins, carbohydrates, and fats. At lunch and dinner, there are also always fibers, meaning vegetables. This is very important in trying to balance nutrition as much as possible. In the mitochondrial patients with diabetes, we will prefer whole grains food, adding 5 to 6 goji berries, which help maintain stable blood sugar level and avoid glycemic spikes. We will use cinnamon because a study conducted at the Boston University showed that 1 gram of cinnamon per day helps prevent diabetes. We will also try as much as possible to eat fruit after meals, because after meals the fiber taken in with carbohydrates and vegetables helps prevent glycemic spikes. I remind you of the importance of antioxidant food. You can now refer to the table to know which foods have the highest antioxidant power. Increase the consumption of anti-inflammatory foods and naturally limit those that instead increase inflammation. As I already mentioned, it is important to try to follow a genetically based diet by increasing certain food that help counteract oxidative stress, and by decreasing other which instead create inflammation, and this also helps us optimize the effect of therapy. Nutritional treatment in mitochondrial disease is a specific, personalized intervention for each individual. It should begin at the time of diagnosis and continue throughout life with appropriate adjustment based on growth, this progression, and other conditions. With this, I conclude. Thank you for listening. I hope I have been helpful. For any question in the future, I will leave you my email. Thanks again to IMP and Paola Morandi for the trust and the great opportunity.
Thank you so much, Dr. Camera. We so appreciate your time and your expertise in this area. It's been a really fascinating talk, and I certainly have learned a lot from it. So thank you. We're going to save questions until a little later in the webinar. And now I would like to introduce Dr. Lopez Sanchez, who is going to talk about LHON in Australia and determining the risk of vision loss. So I'd like to turn it over to Dr. Lopez Sanchez. Thank you.
Thank you. First of all, thank you very much for the invitation to present and speak today at the International LHON Awareness Day 2025. It's a pleasure to be here and to talk a little bit about the work we have been doing on Leber hereditary optic neuropathy in Australia, especially around determining the risk of vision loss. First, I want to share this slide because it shows some of the people who are conducting the work. So although I'm presenting, this is obviously a team effort, and we are very lucky in Australia that we have a dedicated group of clinicians, researchers, and allied health professionals focused on LHON. And these are some of the colleagues I work with, but there are many others. So we are really fortunate in Australia to have this collaborative network of health professionals, clinicians, and researchers, and also community members who are directly impacted by LHON, working and researching different aspects of this condition. So Dr. Kemmer has already talked a little bit about the background and general information on LHON, but I just have a couple of slides on the genetics and the clinical symptoms of LHON. So I call it LHON. I know some people call it LHON, but LHON is a primary mitochondrial disease caused by a genetic change in the mitochondrial DNA that we all inherit from our mother. There are 3 primary LHON mutations or variants, genetic variants, that are responsible for about 90 to 95% of cases in most countries. And these are shown here. In terms of the clinical features of LHON, in most cases, LHON manifests as painless, sudden, and irreversible vision loss in one eye. And this is followed by vision loss in the second eye within about a year. This is the case in, at least in our experience in Australia, in about 95% of cases. Some people do experience spontaneous recovery, especially in the first year of vision loss onset. This is often the case in younger people with the 14484 genetic change. Now, I just want to acknowledge that the impact of LHON goes well beyond the vision loss. We are very lucky to collaborate and work with many LHON community members in Australia, and that's really taught us that the impact of vision loss due to LHON is significant, and it impacts an individual's life, but also their families, their friends, and the wider community. It can sometimes lead to a loss of independence, challenges accessing mainstream education, employment, reduced income, decreased mobility, and in the vast majority of cases, it has an impact on an individual's mental health. And I think it is important that we acknowledge this aspect of the impact of LHON as researchers. It goes well beyond the clinical manifestations. Yes. So as I said, we're very lucky in Australia that we have been following the epidemiology of LHON since the early 1990s. And this is really thanks to the pioneering work of Professor David Mackey, who first conducted the first epidemiologic study of LHON in Australia back in 1992. And he has actually been following these families over the last 30 years, and this is the work that I'm now benefiting from, and the collaborations and engagement that we have with many LHON community members. So what Professor Mackey found back in 1992, when he conducted the first audit of LHON in Australia, was that there were 20 independent families impacted by LHON, 291 affected individuals, and 1,700 asymptomatic carriers. So we decided to update and publish these numbers, this information in 2021. So I led that work. in collaboration with our colleagues, and published this paper that not only updated the epidemiology of LHON in Australia, but also aimed to establish the risk of vision loss for people with LHON genetic variants. So what we found in 2021 was that there were 96 independent LHON Australian families. 56 of them were new and 40 of them were updated pedigree. So families that were known to us, and we only updated the vision loss status, added people and removed some people who had died. We learned that as of 2021, there had been 620 people who had lost vision due to LHON in Australia, and there were 350 people living with vision loss due to LHON. In about 5,000 asymptomatic carriers who have a genetic variant but no vision loss. So I just want to highlight here that we have a comprehensive clinical registry in Australia that has facilitated this deep understanding of the LHON community in Australia. This has allowed us to update the risk of vision loss for people with LHON genetic variants. So it was previously thought that about 50% of men and 10% of women with a LHON genetic variant would lose vision. But this didn't reflect what we saw anecdotally, but also with our updated epidemiology work. And so what we found is that in Australia, in our Australian-wide study, 1 in 6 men, or about 17% of men with a LHON genetic variant are going to lose vision, and 1 in 20 women, or 5%, lose vision. And this is a really important finding because it basically shows that there is a much lower risk of vision loss. And this has led to changes in the genetic counseling that people receive when they first encounter a diagnosis of LHON. We know that several patient organizations have updated their information online, and we think this is really, really important because it has real life consequences for the decisions that people make once they find out they have that the LHON is running in their family. Now we and others, so I'm highlighting here work by us, but also by colleagues in Sydney who conducted work, similar work in an independent manner, found that a large proportion of people with a LHON genetic variant never lose vision. So we wanted to look at what happens in the general population. So the data I presented before was obtained from our clinical registry, and basically it's a disease, what we call a disease cohort. So these are people we know, families we know have a LHON genetic variant. But we wanted to see what happens in the general population. And we thought this was really important because, at least in Australia, genetic screening is becoming much more popular, either for research purposes or for family planning. And we were concerned about incidental findings of LHON variants and the consequences this could have for individuals who had an incidental finding of a LHON variant for a genetic screening for an unrelated condition. So what we found, looking at a large cohort using the UK Biobank, so this is 400,000 individuals, and an Australian cohort of 50,000 individuals. So these are healthy people, so not that are not known to have LHON. Is that in the general population, LHON gene variants are actually quite common. So both in the UK and Australian studies, we and our colleagues in Sydney, led by Professor Caroline Su, found that LHON gene variants are quite common in the general population, and they're found in about 1 in 800 to 1,000 people. And to give you an idea, this is similar to the BRCA1 genes that are associated with breast cancer. So it's actually much more common than our studies in disease cohorts and other studies showed. However, none of the carriers tested in the UK and Australian general population cohorts had severe vision loss. So what we can interpret from this is that although LHON gene variants are quite common in the general population, most carriers in the general population don't lose vision, and that the penetrance, or the number of people who actually go on to lose vision and have a genetic variant in the general population is much lower than 17% or 5% we found in our LHON cohort. It's actually close to 2%. So what does this mean for people with LHON? So in the general population, LHON gene variants are common, but most people will not lose vision. And as I said, this is quite relevant for people who are undergoing genetic screening for unrelated conditions, or for those who participate in research that involves a genetic testing that may include LHON genetic variants. However, we know that within known LHON families, the risk is it's a bit higher, but it's still much lower than previously thought. So it is 70% for men, or 1 in 6, and 5% for women, or 1 in 20. We've learned a lot about LHON, both within families and in the general population. And what we've learned is that the risk of vision loss really varies within families. And we know that there are some clear factors, such as the mitochondrial background of an individual, also known as the mitochondrial haplogroup. And there are some haplogroups, such as haplogroup J, that seem to confer a higher risk, while some other haplogroups, such as haplogroup H, seem to be protective. But we know from research that we're doing, and also from research done in other countries, that there are definitely other genetic as well as environmental factors that contribute to an individual's risk of vision loss. Finally, all this work really highlighted the importance of genetic counseling. And we know that people are making all sorts of decisions about their life and family planning, employment, etc., when they know that there's a LHON variant in their family. So for this reason, we created a resource, a paper. This is a peer-reviewed open access, so it can be accessed by anyone online. Guide for genetic counselors and health professionals. And really the idea is to provide guidance based on 30 plus years of experience working with LHON families in Australia, to provide, to help health professionals provide tailored advice for each family member. And we really found that, within a LHON family, advice needs to be tailored for the affected person, the mother, the siblings, the partners, the children. They all have very unique questions, and tailored advice is really important. We also highlight the importance of emotional support, low vision aids, and adaptive technology strategies that are available to many people with vision loss. And we really hope that this can help families understand and navigate the individual risk and make informed decisions. This is also important in Australia because we are currently going through a clinical trial for mitochondrial donation, and all these questions and genetic counseling will become really important in the coming years. Thank you very much. I'll be happy to answer any questions, although it's a little bit late, so I might have to head off soon, but thank you very much.
Thank you so much, Dr. Lopez Sanchez. We really appreciate you staying up so late in your evening and for your wonderful presentation. That was absolutely fascinating. Paula, did you want to ask Dr. Lopez Sanchez just one question? And then what we might do, I know we have a few questions, but perhaps we can send those to you, Dr. Lopez Sanchez, and then we will share them with the group following following the webinar.
Absolutely, I'd be happy to answer any questions. Yeah.
Thank you. Paula, you're on mute. If you want to just ask maybe one question now, and then we'll let Dr. Lopez Sanchez drop off, and then we'll ask most of the questions to our other speakers in a little while.
I think we'll send some questions at the end, Joe, so that we can continue, and maybe we'll send everybody questions at the end. Thank you.
Okay, wonderful. All right. Thank you so much, Dr. Lopez Sanchez. We will let you head to bed. I know it's after midnight for you. So thank you again.
Thank you very much. And thanks a lot for the invitation to speak. Thank you. Bye.
Thank you. Thank you so much.
Thank you. That was a wonderful presentation. I would now like to invite Dr. Giaccani to give his presentation.
Thank you. It's a great pleasure to be here. I would like to thank the invitation to Paula, to International Mito, to Pedro Mendes, from Mito Brazil. And I would like also to congratulate Dr. Camera and Dr. Lopez Sanchez for the great presentations. And let's talk a little bit about new perspectives in diagnosis and treatment for LHON. So I have no conflict of interest as the majority of neuro-ophthalmologists. And we will be talking a little bit of generalities, the clinical course, diagnosis, and finally the treatment of the disease. So labor, the incidence varies, but it's usually 0.15 per 100,000 individual. The estimated incidence in Europe, in the US, vary to 1 to 400 to 1 to 500 new cases per year. It affected mostly patients around 15 to 35 years old, and the best corrected visual acuity at the end is less than 2200. As we know, and it has been mentioned, it's a mitochondrial disease maternally inherited. It presents as a sudden, painless central vision loss, initially in one eye and subsequently in the other eye. And in general, it's a symmetric disease with poor functional recovery. We see a ganglion cell layer thinning occurring before the onset of vision loss that stabilize around 6 months after the vision loss, and almost 100% of the patients present with bilateral involvement. This is just to show, as we almost everybody know, that an affected mother will pass the disease, will transmit the disease to all of the affected children, and an affected father will not. We have, as it has been mentioned, several pedigrees. These are the most common, 11778 being the most common in most of the studies. But it's important to mention also that every year we have new pedigrees being identified, and even Pedro Mendes, that is our president of Mitochondrial Brazil, is an example of this. when he presented his clinical symptoms, he saw several doctors, and finally, when someone suspected of LHON, the test was negative. He came to saw me. We had a big conversation when I told him that even with the test being negative, his clinical presentation was very suggestive of LHON. We started him on treatment on idebenone, and a few years, maybe a couple years later, he went to Italy to visit Dr. Carelli, that is part of our group. And finally, he had his test positive for a different pedigree that had not been described or published yet. As it has been said, it's more common in men in this proportion, 2.5 to 6 per one woman. Most of the cases presents with symptoms of optic neuropathies as dyschromatopsy and central scotomas in the visual field. In fundoscopy, we see usually in the acute phases a circumpapillary telangiectasis, peripapillary RNFL swelling, initially vertical, an absence of contract leakage, which is important in the differential diagnosis. In the evolution of the disease, we see an horizontal RNFL loss and finally optic atrophy. As I said, the prognosis is still poor. In rare cases, we see some neurological and cardiac findings. And as it was already mentioned, genetic counseling is very important. This is in the very beginning of the disease, where we see pretty much just the swelling of the optic nerve phase. This again in the beginning of the disease with a small central scotoma. Here we see more of the swelling. As the time goes by, the central scotoma gets a little bigger. Here, the OCT showing that swelling of the optic nerve. And 1 year later, the central scotoma gets bigger, and we see now the loss of the fibers and the pale optic disc and the optic atrophy. And here in the OCT, we see the loss of the RNFL. Here we can see in both eyes, and the loss of the ganglion cell layers as well. A bit of the treatment overview. We have to remember that some groups present spontaneous recovery more than others, 14484 being the one that presents best rates of spontaneous recovery. We need to remember also to avoid risk factors, mainly alcohol and tobacco. And in terms of treatment options, what we have now is basically idebenone. We had studied at USC and here in Brazil also in a big family that we followed for over 10 years, this other molecule called F743, but it's not available. We have still a few patients that we keep following, but the results are similar to idebenone. And we will be talking about gene therapy. That is probably what everybody is looking for and expecting, as we physicians are as well. So idebenone is a short-chain benzocainone that its primary action is to facilitate ATP production or energy production, and a secondary action is as an antioxidant. As a background, it all started with Ihara and co-authors that described a case reported of idebenone in MELAS treatment and later studied in other mitochondrial diseases. And in 1992, Mashima and co-authors described a remission of a case of LHON after idebenone. And subsequent studies showed potential therapeutic use due to its antioxidant properties and the ability to bypass the complex 1 defect in this disease and these patients. This was a very important trial that it was actually what made idebenone being accepted as the treatment for LHON. It was a multi-center, double-blind, randomized, placebo-controlled trial that 85 patients with LHON in all mutations were followed for 24 weeks in the dose of 900 milligrams a day versus the similar number of patients that were treated with placebo, and the primary endpoint was visual acuity recovery, and idebenone was considered safe and well tolerated, and the primary endpoint was achieved. Later, other studies were performed. Carelli, Lamorgia from our group did this retrospective study to evaluate effectiveness of idebenone in visual recovery of labors. And they concluded that the early treatment delayed the involvement of the contralateral eye, and the response varied by subgroup, being 11.778 the best responder versus 34.60 being the last responder. I will present you now an interesting case that I have been following here in São Paulo, Brazil. It's a male patient, 21 years old, that now is 23 years old, musician, natural and living in São Paulo, that presented to me 2.5 years ago. He presented in August of 2022 with a sudden vision loss in the left eye. He was treated with IV steroids with no improvement. That then was treated with plasmapheresis with no improvement. And then in December of the same year, the right eye was affected, and a new steroid pulse was performed in January of 23. So this is interesting because in this patient, he had an MRI that showed enhancing lesions consistent with MS. And this is a bit atypical because what we see a lot here in Brazil, in Latin America, and in several places is that these patients with LHON are wrongly treated initially when they showed to general ophthalmologists or to neurologists with the sudden visual loss. They are treated with IV steroids, and this is wrong. But in this case, no, the patient presented with these enhancing lesions in the MRI that were consistent with MS. He had aquaporin 4 negative, anti-MOG negative. So he was started on treatment with natalizumab. After 4 doses, he developed JC positive. Then he was stopped with natalizumab, and he was started on Ocrevus. He had a family history of his mother with lupus and the sister with Still syndrome. This is just a report of the MRI. I couldn't get the real MRI, but just to show that he had the lesions consistent with MS. And then the clinical presentation, his best corrected visual acuity when he presented to me was 2400 in the right eye, and counting fingers to 3 meters for distance, 2080 and 2500 for near. Pupils were normal. Intraocular pressures were normal. Reflexes were a little decreased with an RAPD in the left. Color vision was also decreased, being severely decreased in the left. And in the fundus examination, he had an hyperemic disc edema with peripapillary RNFL swelling and a diffuse yellowish optic atrophy in the left. This is his 10-2 visual field. At presentation, we see a complete central scotoma in the left and almost complete in the right. This is a 24-2. Again, a complete central scotoma in the left and a central scotoma dense and pretty big in the right. So what do we have so far? We have a clinically defined MS in a young male patient that a little bit atypical, and a dense and an extensive central scotoma bilateral, and a severe visual acuity loss without improvement. So what to do now? As we all know, this is also a little bit atypical for MS, because usually in optic neuritis, we see a better visual acuity and visual field recovery with treatment. So this was a bit atypical to me. So I ordered genetic testing that was positive for LHON, for 11778 mutation. So I started the patient on idebenone 750 milligrams a day. This is the positive test from a laboratory here in Brazil. 3 months later, we have again this patient positive for LHON and MS. The visual acuity got a little bit better. Was counting finger in the left eye. Now it was to 2400 in both eyes. Color vision was a little bit better in the left. Again, he didn't see any of the plates. Now he could see one of the plates. Visual field, again, he still had the total scotoma in the left and an enlarged central scotoma in the right. OCT, he had mild inferior RNFL swelling in the right and a 50% RNFL loss, that it was worse in the left. So due to these findings, I decided to increase his dose to 850 milligrams a day and recheck in 3 months. So this was his visual field, the 24-2, that it was a little bit worse, if you remember, in the right. And 3 months later, he reports improvement for distance and reading. And actually, it was a little bit better. It was 1 line better in the right. He was now 2200. Color vision was better in the right also. He was 6 out of 20. And in the visual field, the scotoma was a bit better also in the right. This is why he was mentioning that the visual acuity was better. And the plan was to maintain the therapy. So here is to show the visual field really showing the scotoma a little bit smaller in the right, as you can see, comparing to this one. So this was October 23. In May 24, he returned with a visual acuity of 2015 in the right eye and 2400 in the left. So this is really atypical. This is not what we normally see in these patients. Ishihara, he was 8.5 out of 12 plates in the right eye. In the left, it didn't change. Visual field had improved again in the right eye, and the plan was to maintain the conduct and see here the dramatic improvement in the visual field in the right. So let's show this one in June 23, improvement to October 23, and now in May 24, we can see a dramatic change in the central scotoma and in the visual field from 2400 to 2015, which is a completely normal vision. Here is just to show you the patient reading. Sorry that for the quality of the video. So I'm just saying that it's a patient with labors with 1 year and 3 months of treatment, that after 1 year and 3 months of treatment is 2015, all 5 letters. Of course, him and his mom and the family and me, we were all very happy. Here again, and showing that his visual acuity in the beginning was 2400 less 1 letter, so it was less than 2400, and now after 1 year is 2015. So in conclusion, this is a case of atypical LHON 11778 mutation associated with MS, treated with idebenone and Ocrevus. An excellent unilateral visual recovery, and the questions that I bring here was idebenone and Ocrevus association beneficial? Will this effect be sustained? For how long? Actually, I have seen the patient maybe 2 weeks ago, and I'm sorry that I didn't include the results, but the central scotoma is even smaller. The patient is still 2015 and J1 for near. He's doing all his activities, he drives, he does everything. And if anyone would have any other therapeutic suggestions. So now we have almost 2 years that the patient has been followed and treated with 2015 vision. And again, genetic counseling has been mentioned already. And just remember that the risk of bilateral visual loss depends on sex and disease penetrance, and female carriers have 85% chance of being homoplasmic, and they transmit the mutation DNA to all the children. And finally, let's talk a little bit about gene therapy, that it's what everybody's expecting. We have phase 1 and 2 completed. We have 3 phase 3 studies completed, reverse, rescue, and restore, that we are following at USC, UCLA, that I work with Dr. Sadoun, and in Italy also all of them are multi-center studies. And another ongoing phase 3 study, the Reflect, that now is pretty much finished, and a new phase 3 study, Recover, to address regulatory requirements in US and Europe to begin in 2026. So this is just to remember basics of the gene therapy. The gene is encapsulated in a viral vector. It gets into, it's transcribed into the nucleus, and from the nucleus, it is delivered to the mitochondrial surface, and then it produces the normal proteins. So this again is to show some of the studies. We had 252 treated patients, so 4 phase 3 studies with long-term follow-up. The reverse and rescue studies completed with 5-year follow-up and reflect ongoing long-term follow-up study also. The reflect phase 3 is the double mass randomized versus placebo in the second affect eye. So we have the first affect and the second affected eye versus placebo. And this is also to compare the studies. The reverse, it was patients with 6 months to 1 year, and it was unilaterally treated. Rescue was onset of the disease less than 6 months, 39 patients unilaterally treated, and restores, it was from 2 to 5 years and bilaterally treated. So this is just to compare the studies and the results. So we have in all of them, we can see that we had more than 20 characters in the first and second eye at 4 years, at 5 years. So showing that the primary end line of the studies were achieved, but this was pretty much the problem, that the contralateral eye that was not treated also showed improvement. So we will talk a bit more about this, but this was pretty much the problem, and this was the reason why that the regulatory agencies didn't accept the results. So this again showing different studies at 4 or 5 years and the percentage of improvement. And different studies also compared the results of gene therapy versus natural history of the disease and idebenone, and the results were even better, showing that the results in general, the results of the gene therapy was twice better than idebenone and 3 times better than the natural history of the disease. So this is showing study by study, but all of them had good results in general. In comparing, summarizing all of the results of all of the studies, a gain of 22 letters, which is pretty good for this disease. And the meta-analysis that compared again the 3 strategies, natural history, idebenone treated, and gene therapy, as I said, showing that the results with gene therapy were superior than idebenone, twice superior than idebenone, and 3 times superior than the natural history of the disease. And this showing the studies with a pretty large group of patients being followed for a large time so far, 4 or 5 years, showing that the results are stable. And in conclusion, this was the first meta-analysis of visual outcomes conducted in LHON patients. And as I said, gene therapy triples visual recurrence versus no treatment, and doubles visual recurrence versus idebenone. So this again showing the results in different studies, showing one eye versus two eyes. And in conclusion, again, triples the results versus non-natural history and doubles the results versus idebenone. The dose effect that reflect these studies show an additional benefit with a bilateral injection comparing to unilateral injection. And these results suggest that a dose effect of gene therapy support its efficacy. The improvement of the best correct visual acuity is maintained over time, up to 6.1 years post-treatment. And about the contralateral therapeutic effect, it was shown already in some studies that the viral pass through the optic chiasm to the contralateral eye. And this was probably the reason that we saw improvement in the contralateral eye. But once this was not what the study was proposed to, the agencies didn't accept the results. So how are we now in gene therapy? There's no approval so far, unfortunately, neither by the agencies in the US or the agency in Europe. And a new clinical trial is to be started in 2026, probably by the end of the year. So we probably need around 3 more years to conclude this new study, to then, if these results are still the same, then they are again going to be presented to the agencies, and hopefully we expect that it's going to be accepted and we will have good news about gene therapy. But so far, this is how we are up to this moment. So thank you very much to your attention. Grazie mille. And again, it was a huge pleasure to be here talking to you.
Thank you so much, Professor Ciocani. That was absolutely fascinating and just, yeah, so interesting to hear about particularly the case study that you shared. So thank you. We have got a few questions. I can see that Dr. Camara is responding to some of them in the chat, which is fantastic. Dr. Ciocani, I'm going to ask you this one live, if that's okay, from Lisa. She says, it's great that the case you presented had such a great vision recovery. You mentioned that his mum has been diagnosed with lupus and his sister with Still syndrome. Now that you've discovered that the proband has an LHON 1177.8 mutation, is it worth exploring the possibility that the symptoms experienced by his mum and sister are actually associated with them also carrying an LHON 1177.8 mutation?
Yes, that's a great question, Lisa, and thank you for the question. The mom has been followed. The sister doesn't live here in Brazil, so I can't examine the sister, but the mom has a complete normal neuro-ophthalmological examination, and we are following both the mom and the kid with immunologist also doing a huge immunological examination and follow-up to see if we can find something else. And then, of course, if we do, I would share these results with you guys. But so far, we couldn't find anything else. I don't know if this is exactly what you asked, but I think it is. I can hear you, Joe.
Apologies.
Oh,
Could you stop sharing your screen, please, and then we'll be able to see you as you're
Sure.
talking. Thank you. That's wonderful. That's fantastic. Thank you so
Is
much.
that better?
Yeah, I think so. I'll have a.
Now,
Oh no, I've got your.
let me see.
Don't worry, we can have a play with it. I'm going to while we're sorting out the screen, I'm going to ask you another question. Now, Dr. Comrie has also answered it, but I'd like to pose it to you as well as a clinician. So when should treatment with idebenone start? Immediately or after the dynamic phase? Dr. Comrie said immediately, but you must ask your neurologist. Professor Ciccani.
When was the treatment should be started?
Yes, when should it be started?
This is also a very good question. We start the treatment here after the beginning of the symptoms. For example, we always have, and this is a doubt that presented to all of the neuro-ophthalmologists and let me see if I can to all of the neuro-ophthalmologists, if, for example, in a sibling presenting with preclinical presentations as swelling of the RNFL, if we could or should start these patients in treatment because they are risk patients, but so far we haven't. We follow these patients, and once they start losing vision, once they really get into the disease, then we start then in idebenone.
Thank you. Thank you so
Thank
much.
you.
We have another question with regards to idebenone and pregnant women. Would be really interested, Professor Ciccani, on your thoughts on that, whether pregnant women should take it or could take it.
This is also not completely clear. To my knowledge, there are not a lot of studies done with pregnant women, but in theory, idebenone is pretty much a supplement. So we have here again two ways to follow. If we go to one way that it's a supplement and considering other studies to similar supplements, we could use to pregnant women. But if we go to the way that there are no studies available with pregnant women, then we should avoid. Myself, I avoid in pregnant women, especially because it's a long-term treatment. It's not something acute. Usually we keep these patients in treatment for years and years. Usually I don't take my patients off idebenone. This is also another question that we always have in mind, like, do you take your patients off unless they have bad results? And this was also a study done and presented at the last NANOS presentation, that the conclusions were that idebenone is safe to LHON patients. It should be used in 11778 and 14484, and only in 3460 if we don't see results over a certain amount of time, then we could stop the treatment. But otherwise, we should keep the treatment as long as possible. We understand that, especially in poorer countries, it's always something to consider. It's not cheap. The drug is expensive. So we always have this in mind, meaning sometimes we don't have great results. We have partial results, and the patients always expect good results, and we also always expect good results, and that's why we are all so much looking forward new treatments and like the gene therapy. But once we have partial results and the patients are not getting worse, usually we keep these patients, at least here in Brazil and in the US, and I believe in Italy as well. We keep these patients in treatment, under treatment for a long period of time.
Thank you. Thank you so much. We've got some more questions coming in. I'm very aware that we have 2 minutes of the webinar left. So what I will do, if it's okay with our wonderful speakers, is I will forward these questions on to you after the presentations, after the webinar has completed. And if you don't mind responding to me in written form, I will then be able to share the answers with the participants. Thank you so much to Professor Ciocani and to Dr. Camara, who is still with us. Paula, I'll hand over to you to say a few last words.
Thank you, Jo. As we come to the end of today's webinar, I really want to take a moment to reflect on what we've heard, and more importantly, what we're taking with us. We've learned that nutrition is not just a complementary therapy. It is part of the foundational care that every person living with mitochondrial diseases deserves. We've heard about emerging research, patient-centered strategies, and the vital importance of individualized care. Most of all, we've seen how collaboration across countries, discipline, and perspectives can lead to real change. To our incredible speakers, Dr. Isabel Sanchez, thank you for bringing clarity to complex biochemistry and showing how science can be translated into practical steps. Dr. Marzia Camera, your clinical insight and patient-centered approach have reminded us that the human experiences is just as important as the research. And Dr. Felipe Ciocani, your work highlights the urgent need to continue studying nutrition not just as a support tool, but as an integral part of mitochondrial disease management. To all the patients and families joining us today, you are the reason we are here. Your experiences, questions, and voices are what drive research forward, inform clinical practice, and inspire global collaboration. And finally, to everyone behind the scenes at International Mito Patients, thank you for making this event happen, not just logistically, but with heart. On this International LHON Awareness Day, let us recommit to raising awareness, supporting each other, and continuing to ask the important questions together. Thank you for being part of this important conversation. Stay safe, stay hopeful, and stay connected. Thanks, everybody.
Thank you so much, Paula. Thank you so much to all of our speakers, and apologies again for the technical issues that we had in the beginning. Thank you so much for your patience while we sorted those out. I'll look forward to sharing the recording of the webinar next week, and we will also get that translation sorted and shared as well. So thank you so much, everybody. Have a wonderful weekend as you get to it. Thank you.
Thank you.